Hello, dear colleagues. I am Dr. Milan Uzelac. I'm speaking from Belgrade. During this webinar, we will have opportunity to introduce the basic implant planning tools and the strategy. Just after introduction, I will turn my camera off. I would just kindly ask you to confirm me on the chat if everything about the presentation, do you see it okay, so I could continue on? Okay, I will turn my camera off so you could have a better view and a better size of view. And now we can start. I'm here on behalf of the Cowboy Care company, and my personal pleasure is to cooperate with the KaVo for past few years and to use their gear for more than 10 years. I need to tell that all our x-rays and all our interpretations are done on Cowboy Care equipment, and also interpretations are done on on-demand 3D software. Our intention is to make ourselves comfortable and to support you with the fact that you have a really powerful tool on your demand, and that we are really able to do a lot of things, a lot of clinical assessments in general, or in this instance for implantology. And also, I would mention that the quality of the recorded session, which you can look afterward, is a little bit better than this live session, and you will have opportunity to see and to repeat some details which could probably be in less quality than we are used to have in the live demonstrations. Also, we are accompanied here, and we have a company by Dr. Mateusz Spinaj from Poland, and he will be able to support you as administrator of this web meeting to answer some questions. And also in the coming minutes, we will have support from the Miloš Zimonic, who is a representative of a KaVo company. And if you have any kind of a commercial issues to ask, he will be here to answer you and help you and to direct you in the right manner. So we will go further on. And when I was my first contact with implantology was with this kind of X-ray pictures, and this kind of clinical actions you can see on the slide were really necessary so you could try to assess and try to decide what kind of a clinical action you would need to do or you can do. And honestly, for me, it was a little bit surprising, and it was I was thinking about those implantologists who were doing that in those times as if they are some kind of superheroes, because I really couldn't see anything about on these old X-ray pictures. And luckily, our story is we have our happily ever after, and at the end we got a quite better perspective, because when I started to use I introduced myself as an operator in the field of implantology, it was really much more comfortable, much more accurate to use these clear and these really potent radiological images and constructions, which gave me confidence that I can act in almost all situations, whether it is just initial implant treatment, or it is a bone augmentation, or any another kind of issue we should solve. So at the beginning, I would like to say that it is necessary not to misunderstand CBCT recordings by themselves and to put them in the first place. It is really necessary to put our recordings in the middle or in the line of all our diagnostic issues, and because it will keep us from mistakes. It will help us to make as a small number of mistakes as it is possible, and it is just possible if we pay attention to all details in the same manner. For the beginning, our main tool in on-demand software dealing with implant planning is the so-called dental volume reformat, and it is featuring a lot of tools which will help us to do the basic implant planning procedures. It will help us to understand our tasks. It will help us to do the planning, and honestly, to say, the majority of the implant planning procedures are done, at least in our country, just by the native X-ray pictures. During this year, I hope we will have a big change, because some additional tools will be economically available here in the market, and we will have intraoral scanners which will be available more than previously. We will have implant guide the softwares available for the guided to production of the guides in the implant surgery, and I hope that during this year or the next year we will be able to put our quality one step forward. We will be able to put our quality in our treatment one step forward, and to make us a little bit more precise, or a little bit more confident in the procedures. For me, it is always necessary to know to know where I started from, and if I look the picture on the left side, where it was almost impossible to make any kind of orientation, we could see on that picture what we really wanted to see. But when we are going to operation, it was really like opening surprise box. It could be completely different thing. That whole technique was really radiological operator sensitive technique, and you should have really experienced operator to make at least acceptable picture. So today we are looking on the right side. We are in a position to have a picture with no superimposition of the image layers. We have pictures without deformation, and we have accurate measurements tools. Moreover, we have implant planning tools. We have possibility to put into virtual world accurate dimensions of the virtual implants, which will help us to understand the clinical situation we are really dealing with. Getting experience is always big issue, and it is important issue for us, and this is actually the first slide on which I was supposed to give the analysis for another colleague, in which he would need to place an implant. These size you can see on this slide were really strange for me, because I didn't have opportunity to see those kind of dimensions, and I asked my guy from a company who is responsible in Serbia for the presentation. I told him, oh, please, we need to check this. This is not something, it's not good, because the size cannot be this big. Then we put a known size of implant healing, on the phantom head, and we did the measurements, and it was obvious that the software is not lying us. So we need to do some orientations to be able to know whether we are orienting ourselves correctly or not. Although we are not advised in any kind of articles to make control CBCTs in order to see the result of our surgery. In the beginning, we would like to see what actually was the result of our surgery. And on these pictures, you could see the implant 6 or 8 millimeters, where you cannot measure, or you can measure half of millimeter distance from the mandibular canal, or 1.5 millimeter distance from mandibular canal. And some of the people could just argue that this should not be advice for the regular clinical actions, and I can tell that they are right. But sometimes we need some actions, and the main issue I'm telling is that CBCT is giving us the accurate data in which we could believe, and with really careful surgical actions, we really can use the maximum of the remaining biological capacity, or the remaining alveolar bone in our situation. One of the latest reviews of the literature in implantology is telling us that depending on many parameters, we should, after all, have precision, which is, let's say, a fifth of 1 millimeter. If we consider any kind of a clinical action that we really do, the precision which is in that high is really acceptable, and more than acceptable and satisfying for us. Also, it is necessary to talk a little bit about the goals of the pre-surgical dental implant imaging, and you can see the 5 items here, and we will talk about every specific of them a little bit more. So the first 2 goals are to establish morphological characteristics of the residual alveolar ridge, and also to establish the orientation. Also, we need to make measures, and these are the examples of some situation that could influence our treatment more or less, and it could just make a difference when we are trying to do the follow-ups on the 2D X-ray technology, that maybe we didn't use the whole potential of the bone, but actually CBCT is giving accurate data for us, and we are really available to understand this. So in the middle picture, we will see the significant undermining of the lingual part of the ridge, and we will understand that when we are performing the procedure in this part, that we will have to change the inclination of the implant, which could lead us to some prosthetic problems, or we will need to use shorter implants to avoid the damage to the lingual cortex, or lingual cortex will stop us from making planned length for the implant. So the undermined situation here will show us what size or the direction of the implant we will be able to choose. Also, the picture on the right side is important to know when you have this kind of configuration of the alveolar ridge, maybe we should consider for our patients to give or to ensure them that their teeth in the present situation should deserve as much periodontal treatment as we can give them, because the proposed implant treatment will ask for a lot of clinical actions to reconstruct that in the proper manner. Also, another goal is to identify local anatomic or pathological conditions within alveolar ridge, which will allow us or disable us for the implant placement. So in this picture, we could see really big lesion, and also we could see this picture on the 2D, but the thing is that we need to stress that what would be important and what we could see on the cone beam picture is that if we have lateral exits of endodontic infections, then we could clearly identify those things. Also, we should know that if those things are present, it is really necessary to do the endodontic treatment before that. We should have our idea how to manage that point of exit for endodontic infection, because when we are doing our preparation for the implant bed or drilling the bone, the activity of metabolic activity of the bone is not just on that side. It is spreading even the 5 millimeters aside, and we could, even if there is equilibrium of infection amount in that space, we could turn it to exacerbation of the problem with our drilling procedure. Also, opportunity is here to identify inclined roots of the teeth, and we also can identify anatomical landmarks as it is mental foramen or something like that. The probably maximal capacity of the technology is to identify these unusual situations, and on this representation we have really specific one where we have complete septa in the sinus, and this situation is really necessary to be planned carefully, because even if we go to a sinus lift procedure and to bone reconstruction procedure, we will be able to do just the half part of the procedure, and we should think about changing our plan and to use that available bone to change probably maybe to use a small length of implants, or to use some additional tools which will help us to partially elevate the sinus membrane. But we are really we have opportunity to differentiate these kind of specific situations and to manage them in the best possible manner if we really can do it. And also the thing which is probably one of the most important things for us, or it should be the one of the most important things for us, it is that we could correlate imaging findings to the prosthetic plan. Why it is important? Sometimes we go to the implant procedure, we see that there is available bone, we place implants, but then afterward we just encounter problems with that we do not have proper prosthetic elements. Maybe that we will impair some space which is necessary so patient could speak properly. that we will impair some aesthetic elements of prosthetic reconstruction. And that's why the possibility to correlate imaging findings to prosthetic plan is really important thing, because at the really beginning, we will be able to understand and to correct our actions to the result, to the prosthetic result we would like to have at the end of our procedure. So again, we are here to introduce or to remember about our module in on-demand software. It is dental volume reformat, and I will now transfer ourselves to see to introduce ourselves to features that we could see in the software, and that we will be able to act when we are doing our implant plannings. Okay, so what are the main parts of our dental volume reformat? We have the tomographic section, which is the one we identified the most because we appreciate the data most which is gained to us. Also, in sake of orientation, we need to have a panoramic presentation of our CBCT volume. Also, here we could see axial slide, and during the analysis of procedure, I will address what kind of the data we will assess and we will look while we are doing while we are looking on this section. And also we have in the right lower corner, we have 3D reconstruction, which will help us to identify morphological situation and morphological parts of our planned procedure when we do it in radiological view. So the first instance which we would need to address here is also, I will just mention the tools. We have the tools which will, it is tools on the left side, it's called the general tools, and they could help us to move the specific part of the image. Those tools could help us to zoom in or zoom out a part of the pictures. Those they could help us to invert projection of the radiological image. Probably this is much more important when we are trying to assess another kind of pathological issues like foreign bodies or overfillings or cysts or broken root fragments and the other things, but it is present here. Also, we have some measurements tool here. Probably the most important for us is this part with the ruler, and this part which with angle, which will enable us to determine if we are planning some procedures, implant planning procedures with the inclined implants, whether the inclination of the implant will be supported with the prosthetic elements which are available for the implant manufacturers and the prosthetic procedure by itself. Another part of the procedures here is that we configure our arch here by ourselves, that we could make nerve marking. We will talk, it is the next important issue, we will talk about it. We have tools to do the implant positioning and the implant evaluation. We have tools to orientate ourselves in any kind of picture. Probably it is most useful if we are trying to orientate ourselves in this panoramic part of the picture. Also, we have some tools which will help us to reorientate our slices if we could identify that during the acquisition phase of the CBCT volume, there was a little bit wrong orientation of the head of the patient. This is not big deal, because if we do not have motion artifact, which is represented by double pictures on the volume, the orientation of the patients during the acquisition is not important thing, and we can freely change that orientation in this part of our module. And we could change some preferences here, which will show us how the nerve will show when we are trying to project the nerve, or some data about the implant position and the implant markings. Also, these tools, which are called here the tasks, all of those tools are available also on the right click, and it could spare us from a lot of mouse movements or cursor movements, and could speed our actions a lot off, because wherever we are on any kind of the part of our picture, we are able to activate the tools and to use them much more faster than if we go to their picture on the left side. So our next issue, which I would like to talk about, is a possibility to make nerve pathway recognition and the drawing. It is mostly concerned about inferior alveolar nerve, and maybe today we take this tool as it was here for years, or as it were here forever. But when I had the first volume necessary to assess CBCT volume, then we didn't have this dental orientated option, and we didn't have tool to recognize the nerve pathway and to draw the nerve pathway. And sometimes it could be really impossible to follow the whole path of the nerve inside of the jaw. So it was recognized by the developers, and they gave us possibility to recognize the roof or the bottom of the nerve canal in transversal projection or on this panoramic projection, and then to draw the line. And then in all kind of radiological or three-dimensional projections, we are much more potent and much more confident that we could really assess the importance, or to assess the available bony structures. So in Serbia, mainly radiological technicians are doing this kind of recognition when they are after the acquisition phase of the CBCT volume. But I think that although they do their job good in the 95-98%, we could have some specific situations where we have double mental foramen ending, that we have a even double canal, that we have wide canals, that in situations where we have really difficult recognition of canals. So we as a practitioners, I think, should be able to understand the procedure and to do that procedure, or to check that procedure by ourselves, and to be comfortable to decide whether the technician did the good job or not. They do their job in the 98% more than good, but sometimes I have opportunity that they call me and they said, please, could you look at this volume before we present that volume to the practitioner. If we did that, good. And mostly the situation is the difficult recognition or the double mental nerve opening or the double canal in situation. So I will try, although these the representations of the X-ray pictures here much are a little bit lower quality than I could assess them on my computer. And I hope that we will have opportunity in some near future to cooperate directly in some live interactive workshops, and that we will be able to have much more practice and interaction, and to exploit the maximal capacity of the volumes. But as best as we could do it in this moment, I will try to show you the procedure, how we do it, and later on to show to some important notes after we do that procedure. First of all, this arch in the upper left corner, in my opinion, the arch should not follow the the shape of the jaw as closely as it is. The shape should be followed in general, because if we have too much curves drawn while we are marking the arch, then we could have mistakes and wrong orientations on the cross-sectional pictures in the right angles. So I will just show what I'm talking about. And if we are, let's say, trying to modify just one part of this, if we have curved arch here, and with more points of control, then it could show us the wrong picture on the right side of the screen. So when we are drawing the line, we could have a bigger thickness of the slides here. Then we could have the general shape of the jaw, draw our arch according to the general shape of the jaw, and then we will have proper recognition of the cross-sectional, perpendicular cross-sectional images on our right corner in the right side. So what is the necessary to be done when we are trying to make our recognition of the nerve pathway? First, we will choose the minimal thickness of the layer on the panoramic X-ray. We will activate this nerve function on the left side, and then with the mouse we will try to move across the whole volume, so we could recognize really clearly the roof of the nerve and also the bottom here. And when we are really, when we can recognize that, then we can draw some dots, and those dots we finish with the double dot at the end. And when we look at the right point of the screen, it should be finished at the opening of the mental foramen. Also, we will put our line back to so we have one line, not blue and orange here, and we will get back to a thickness which is usually 15 millimeters for panoramic projection here. While when we finished this, then we could check if we are inside of a structure we could recognize as a nerve ending here. And here is a double canal here, but because it is not in a region where we need to perform any kind of action. In this instance, this is not important, but in some another instances, we probably should be able to recognize that this part I am showing here on the right screen is actually the roof of the nerve canal. And when we activate this reference point, it will show us that on panoramic pictures that we did the right orientation for the recognition. I will get back to the presentation, and I will note one really important message for us. The red dot, which is the drawing of the nerve canal, will not fulfill the whole canal always, because the nerve canal can vary, and it is usually 1.5 or 2 millimeters width, but sometimes it can go over 4 millimeters. If we have some unilateral widening of the nerve canal, probably we should consult a maxillofacial surgeon, or we should try to look with colleagues if there are any other health problems with our patient. But usually the canal is 2 millimeters wide, and we should be able to recognize the roof of the canal, and our measurements should be made to the beginning of the roof, so we could plan really carefully the whole procedure later on, and to use appropriate length of the implants. We will get back to some, I will like to stress some basic implant planning principles, which we will use to assess, or which we will use in order to use the tools to make the proper distances between two implants and everything. Also, the point number 4, due to development of these nerve markings and to the confidentiality we can gain with CBCT volumes. Now, even in the strict region of mental foramen, we are able to use this region quite to be confident when we are using available bone in this region, and to use the maximal capacity of available bone, because we have a really accurate diagnosis, and it will show us the accurate position, and we will not need to run far away from the mental foramen and to look for the loop, because the projection itself will help us to use these anatomical structures as best as we could do it. Also, when we are trying to put the virtual implant in the position, we should know that at least we should have 1 millimeter of a bone available to the buccal or to the oral, and that we should have 2 millimeters surrounding bone from the neighboring structures, and the 3 millimeters of bone between two implants. But this first instance, usually we do not have enough bone available, and the CBCT volume will show us which amount of necessary bone augmentation we will need to perform if we are trying to plan implant insertion in a specific site. Also, that 1 millimeter will change if we are in aesthetic region. We should change that to a 2 millimeters. So when we are planning either insertion or the bone augmentation, we should look availability of about 2 millimeters of a buccal bone available in that position. And also in this picture, in the right part of right image, I placed the implant about 6 millimeters in width. And today it is the old picture, and today I prefer to go as less titanium as I can, and to leave as much bone as I can in specific situation. When we are talking about the second rule, it is a 2 millimeter from surrounding bone structures. Sometimes when we have inclined root of the neighboring tooth, if we are confident to orientate ourselves really good, then that distance is really not necessarily to be 2 millimeters, and we can go a little bit closer, because if we do not harm the periodontal ligament by itself, we will not do any harm. You could see at the beginning of the presentations the control X-rays where we were closer than 2 millimeters to the inferior alveolar nerve, but probably we should take a care to be 2 millimeters away. We should keep it when we talk about the distance. But probably the most important and issue on this screen is 3 millimeters of bone in between two implants. Whenever I saw situation where when I place the implants closer than 3 millimeters, I had a problem, because the bone in between two implants is not viable as a bone in between tooth and implant, and we should really give a lot of space, or appropriate space, in between two implants to avoid complications which could occur in the future if that space is not close enough. So if we have in mind those basic instructions, then we could just look how we utilize the basic implant planning tools in the software, and we will have here, if we need to plan one implant to the neighboring tooth, then we should have 2 millimeters distance implant from tooth or from the root. We should have in mind that the average size of the implant is a 4 millimeter diameter, so the half of that size is 2 millimeters. And then if we are planning additional prosthetic space for the molar, we should add 1 or 2 extra millimeters. And when we count all those millimeters, we need to be 4 or 6 millimeters away from the neighboring tooth if we are planning that for the molars, of 4 millimeters if we are planning that for premolars, and 6 millimeters if we are planning the situation for the molars. So get back to the on-demand, and first I will need to remove all these implants I placed as a preparation for the lectures. And on the right click, we always have right click, remove implant, another for any implants we have situation to remove implant. So what available tools we have to measure that 4 to 6 millimeters? We can activate the tool on the right click with the measuring tool and the ruler, and that tool we can use it to assess and to measure, to measure the distance. If we are not confident with that data we are getting, we could do it in another way. We will activate our reference. Reference will come to the starting point, and then with the ruler on the right upper screen, we will count 1, 2, 3, 4, or 5 millimeters away from the most distal position of the root, and that will be the anatomical situation in which we will plan our implant. So when we want to place implant there, we will then activate the right click. We will choose implant. Then we have option pick and place. And we have really large choice of the implants. And even if the implant is not if the implant is not there, you have opportunity, or you can contact your implant dealer. They can contact with our representative, KaVo representative. So then they will contact the designer of on-demand, and it could be integrated into this catalog, or you can do you can make custom dimensions, and you can use your own dimensions of the implants. But why is it important to use these fabricated or inserted dimensions? Because wherever we recognize this screw mark here, it means that we will have a picture or a preview of the chosen implant, and we will be able to orientate ourselves much more confident and much more precisely than if we have just some kind of approximation of the implant side. So I will choose here the implant of the 4 millimeters width and 11 millimeters length. And when we want to place the implant, we just choose position. It is the one we measured before. The double click, he will ask me just to write which position that is. So it could be designed for the implant position, what is the implant position, and then we can move our implants. We need just to place the cursor on the middle of the implant, and we are able to move it on the place. Also, we have a possibility to change inclination of the implant, and that inclination could be changed in all directions. So I choose this implant because of the shape, and I told that we will be able to assess some additional data on this axial section here. I will activate the zoom function, and we will be able to see that that if we go here, that we have a lot of missing buccal bone here, and that it is possible, of course, to place implant, but we will have some prosthetic challenges. We will need to inform patients that they will have a little bit different appearance of teeth at the end. It will be, or we should, if we think in another way, then we will need to place our implant in ideal, let's say ideal position, and then we will need to know that we will need to do a kind of a bone grafting here, which could be seen, the amount of the grafting could be seen here on the three-dimensional picture. Also, I would just stress, although it is not the main issue of our presentation here, that we should always be a little bit reserved when we are looking at this three-dimensional reconstruction, because it is possible to be changed, the sensitivity of the appearance. So probably this is the situation, the most probable situation that we will encounter in our mouth, and we should look for assessment after the correction of these data. So we will need to put as much of sensitivity, increased sensitivity in the 3D reconstruction, so we will be available to look at these data here. But also these parts are evident here, and always these radiological data cannot be changed that much as 3D data here. Of course, then we will go a little bit back to the presentation, and then we will ask ourselves if we need to plan multiple implants, then we will have to go for a situation where we will need to count the distance in between two implants, and always it is 2 times half of the average implant width. It is biological distance between two implants, so it is so far 4 plus 3 is 7. And if we are planning the distance premolar to molar, then we will need to add some prosthetic space, 1 or 2 millimeters. So we are 7 to 9 millimeters distance, one implant from another. What does that mean, and how we will utilize in our tools here in the software? We will activate this right click on the implant. We will go for this tool, which is telling us copy implant. Then he will ask us about the distance. Let's say that we would like 8 millimeter distance. He will ask us about the direction where he will copy the implant. And also we will unbox this part which is telling linked. So we will have free motion of the next implant we will copy on. So here we have another implant, and now we have accurate distance 8 millimeters one from another. And we will change just the properties. We will go right click, implant properties, change, and we will assign a position to implant and confirm that, so we have a right implant position mark when we are presenting that on panorama. What is the next tool we need to address? Next tool is to see if that copy of the implant is on the right position in the this cross-sectional. So we see it is not, that we should take care about the new position of the implant. And mostly if we are doing our positioning without any additional tools, that's the position of the implant. And how we will now, we need one more data more. We will activate measure and the ruler, and we will measure the distance from the tooth to the implant position here. And when we are trying to go for the surgical action, we will need how far from the tooth we will need to go for that specific implant. Okay, again, we will go to the presentation, and we will ask ourselves if we need to plan a bridge where two implants are carrying three units bridge. Then we will count 2 times inter-implant distance. Inter-implant distance as an average could be 7 millimeters plus prosthetic space, and that will be from 14 to 16 millimeters. So let's go again to software. Let's go again to the first position. Then we will also look for the right click, copy implant. We will choose, let's say, 15 or 16 millimeters. It's never mind for this instance. We will direct the copy to the right, unbox linked to make implant free for the movements and to the changes, and we did the copy of the implant. Also, now we will check if the position of the implant is on a good place. We will move that implant on appropriate situation. And now, if we look at the bigger screen, we will see that probably this size of the implant will not fit good at this position. Either we will have to change inclination, which will make a little bit headache when we are doing prosthetic procedures. It will make troubles to make impressions or to position some prosthetic elements. And probably we should, in order to avoid the damage to the lingual cortex, probably we should choose the smaller implant. And what we can do, we activate the right click, then we activate option which is telling us replace implant. It is getting us back to the library of the implants. We will choose the same width, but with less of the length. And we will position that implant, and we will see that probably this implant is much more appropriate for our position than the previous one. Also, I will now unzoom a little bit this picture so I could show you one more instance. When we do not have a correlation of the prosthetic plan in advance, we can use 3 elements to orientate ourselves. The one element is the palatal cusp of the antagonist, and we know that the central fossa will be that we should be somewhere around the palatal cusp of the upper tooth. And if we change the direction of the implant, we will be sure that this situation is clinically acceptable for us. Also, if we need to assess the position when we have neighboring tooth close to the implant planning procedure, we'll get back to the first implant we were planning. And we will change the thickness of the cross-sectional slide here. And we will increase that, let's say, for 15 millimeters. And what that will help us to do, we will have here a kind of ghost picture from the neighboring tooth, and we will know that we need a little bit to change our either orientation, either position. The picture we could see. Now we are here on the number 5 position, and then we could see that either we need to change the orientation of the implant, or we will have to change the position and orientation of the implant. And when we change to the thickness again and go back to the implant position, then we will see that implant position that we will need if we are looking for ideal, I said not optimal nor ideal situation for the implant placement. Then we will inform our patient that augmentation procedure is necessary here in this instance for our patient. Also, we could present the possibility for the patient that if we change that not to do bone augmentation, it is also possible. Probably he will at the beginning after prosthetic reconstruction, because it will be the whole construction will be thicker on the lingual part, he will have a little bit of the discomfort and a little bit changed appearance on the buccal side. But if all other parts of the procedure are done correctly, he will probably have long-lasting restoration. So sometimes we really need to consult patients if he is eager to go for the bone reconstruction or not. It could be a time issue, it could be organization issue, it could be financial issue, and we should look for the solution which will give us as much as it could be given. So let's go back to the presentation. And probably the one of the most sensitive situation for us is the distance planning when we are in a static zone. And now we have a more data to just to look for, and we will look at these data at the end, because I will try to show you how much we get if we correlate our prosthetic plan to implant assessment, and we will do the procedure of how do we correlate the intraoral scan to the CBCT scan at the end of our presentation. So this presentation here is also one situation where we have a post-extraction socket, and I placed this slide a long time ago. It was a group of my friends on our work presentation, and I asked them if this is the situation and if these measurements are correct, what would you do in this specific situation? And whenever somebody asks you to give your opinion according to one slice or according to the one situation, you should tell him that it's probably a tricky question, and he will present you some issue which is not visible here. And my issue here is to introduce you a verification mode, and the verification mode is our possibility to orientate ourselves around 360 degrees around one implant. So it will help us to assess more data and to see whether the whole implant elements are feasible to be done. If we could see in the middle picture, maybe because of the interference with the maxillary sinus, we will have to change the surgical technique. Maybe we will have to change the implant dimension. Maybe in this situation, when we look at the neighboring tooth which have periapical issue, we will need to quit the procedure, or we will change at the end some prosthetic elements which will enable us to do the prosthetic reconstruction. So now we will go back to the program and to see how this where this verification mode is, and how we utilize this and what kind of data we can get from it. So we will have four screens, four windows in the moment. We will, at the upper part, we will see here the part where it is verification mode. We will activate that verification mode. We will zoom our picture in panoramic. And then we will choose which implant we would like to assess in this verification mode. I will click on the implant 4-5 or 45, however we call that. And now a substantial part or orientation on this picture is the implant itself. Implant is the center of our orientation. And when we move this tomographic line, which is marked here blue, and it is really heavy visible on your screen, probably in the upper left picture. When we move across all around the implant, we are in position to see the relation of our implant with the nerve, with the neighboring tooth, or we will be able to see the relation of the tooth and the neighboring implants. Also, it will be possible to see it on the three-dimensional view. This three-dimensional view, because some elements are cut off, is much more easier to assess implant position. We can zoom it, and then with the right click, we can look about the implant position and to see what the actual position of the implant in situation really is. So this verification mode is really, if we have any difficult situation, this is a powerful tool, and it will could help us a lot to orientate ourselves really good. Also, there is also question whether we can assess bone density. We have tool which will help us inside of the program, which is called bone density assessment. And it will give us a kind of a picture where we can see the quality of the bone. And I like to call this tool like a bone quality assessment tool, not bone density assessment tool. And I will tell you why. If we look for the literature will tell us that we are not able to define Hounsfield units on CBCT volumes. They are closely correlated and they have impact on the stability of the implant, but they are not the same. Why the tool itself is, why is it present inside of our software? I believe that is it present because in our software we can incorporate even classical multi-slice scanner data, and then that Hounsfield units, the numbers will be correct. But the next issue for me also is nobody taught me in any kind of my education what I should do with those Hounsfield units. So for me, I prefer to rely on the Lekholm-Zarb classification, which will tell me and introduce me the morphological characteristics of the bone, and it will be from D1 to D4. And on these slides, we could see in the upper part the situation where we have almost absent cortical plate on implant assessment side, which is really rarely seen in the lower jaw. But this specific site was after really massive infection and after the healing. So for us, this was more than we expected after that kind of situation. And in which direction it will direct us? It will direct us that we probably should use a less instrument to prepare the implant bed, or we should use the instrument with the possibility to do osteodensification process during the implant bed preparation. But when we look at the lower picture and we are able to see that we have really dense bone with almost no marrow spaces in the middle of the site, then we should think about choose appropriate implant, which will allow us to be placed with the smallest possible torque, because we do not need it here. if we use the implants with a high torque insertion rate, then we will do probably great damage and probably implant failure. Or we should talk about the implants which are inserted without torque, which are just put in the position as the ones we had opportunity to see to be planned on our previous action inside of the software. Also, when we go further on, we should look about accuracy of the radiological assessment if we have tooth which is present on situation, and whatever kind of the measurements we do or the implant projections we do on that specific place, we should take a care whether we will be able to remove that tooth as easily as we would like to do it, or we should apply some tools to have less invasive tools or techniques to have less invasive extraction of the tooth. So the remaining bone would be exactly the one we were planning to be at the place. Also, even if we do not have tooth in situ present there, we should know that when we are drilling our implant place, we will do the changes. The implant will not appear by itself on the position. It will not be laserly placed there, imploded inside of the bone, and we will do the changes, and probably those changes will make the biggest impact on the buccal bone, and we should look and know that changes in advance to be able to plan some minor or necessary bone augmentation in the cervix of the placed implant. Also, if you are looking for the accuracy of the assessment in relation to the extraction, we could tell that up to 6 weeks or 8 weeks after extraction, the recording could be actual, but we should take our attention to the fact if the reason for the tooth removal was the massive odontogenic or the periodontal infection. If that was the case, then probably even in this period, when we do not expect a large amount of the bone healing, we will have important changes, and then we will need to do to instruct patients that we should go for the fast action if we are looking for that kind of the procedure. And at the end, we should know that we are the most confident in situation when the complete bone healing is done, and it is 6 or even if it is bone augmentation procedure 8 months after bone augmentation procedure, and then in that situation we will have the most reliable data for our assessment. And why we actually need to correlate image findings to the prosthetic plan. This is the one of the situations I shows me, or which will describe us how we can make mistake. I did the planning. I was supposed to place 2 implants on the right side of the mandible, and I told to myself, okay, I will do some bone remodelation. I will cut this upper part, this thin part, and then I will have enough place to place implant, and this could be an ideal situation for the implant placing. And this was the beginning situation we should follow. But when we entered the situation in the upper left screen, I saw that the available bone is not on the position I really need it to be, and that's why we choose the smaller diameter of the implant. We place that implant buccally, and due to these misinterpretations, it was necessary to do the bone grafting procedure to cover this 1/3 of the implant which is exposed and not covered to the bone after the placement. So in the simple manner, we could use radiological markers. What that could be? It could be handmade resin material, temporary crown, which will not give us a lot of artifacts, and we will be able to look for exact shape of the tooth and the position of the tooth we are planning. And then we will be able to see the position of the implant. We will see if the available abutment choice is good for us, and we will be able, there should be one more picture, but we will be able to look at the buccal side here, whether we need bone augmentation or we do not bone augmentation, and what amount of the augmentation will be needed for us. Also, in some complex situations, we will be able to look for situation with the radiological markers also, and we could utilize gutta percha markers. You can see the gutta percha markers here. This is the prosthetic element which was made for another patient. This is just like showing distance here. And for this patient, we placed the gutta percha markers at the middle of the central fossa of the teeth or the positions we needed, and then we were able to see whether according just to the central fossa we have, or according to the position we would like to have, whether we have available bone or we do not have available bone in that situation. So this is something which doesn't cost almost anything, but it gives us a lot of information, at least about the position, and it could just speed up a little bit the initial drilling or the positioning when the drilling procedure is done for our patient. And we had the opportunity to talk about cone beam as a crossroad to our groundwork to the digital dentistry. Digital dentistry in coming years will be reality, our reality, and I am sure that it will be. And as a heart of all the digital procedures, we will have the CBCT. Also, we need to know that in our diagnostic procedures, we will need the photographs, we will need radiological data, we will need optical scannings, and we will need to inform us how to deal in between all these data together. So no other technical concept brought us possibility that we can incorporate prosthetic plan, and that will influence our procedure most than combination of the cone beam itself. So we know that there are two ways to be guided. One is to have stiff or static guides, which will direct in one position our implant drilling procedure, and also in past few months or past year, we could see that the power of the navigated or dynamics system of the surgery is growing, and that probably in the future we will need both of these systems, because we will have different anatomical situations needed to be handled. And also it will be depending on the economical availability of the systems, which system we will use and how it will impact our data planning. We should also know that every step in which we are doing our planning is prone to mistake. We can make mistake on any step we are doing, and we should know what are the possible mistakes in any clinical step we are really doing. So at the end, the cumulative inaccuracy would be acceptable for us. As much as I know, and as I could see in my 16 years of the dental practice, I could see that there is always mistake, and that we always need to thanks a little bit to availability, to ability of the biological system to adapt to our changes and to our imperfections, and that due to that potential, biological potentials, we are able to perform all our procedures. If that wouldn't be like that, then most of our procedures would fail. But we should not rely on that. We should know where we can make mistakes and what extent of mistake it could be on every specific step, so we could control that and make the influence of the mistakes as smaller as it can be at the end of the procedure. For me, the big issue is how do we match the CBCT image data to our prosthetic plan. So I do not know whether I'm going to be clear, because we do not have possibility to stop presentation, and we cannot go to the personal computer and to help each other to understand this, but I will try as best as I can. We need to establish a protocol in which our reference points or the surface points will be possible to be recognized both on the scans and both on the intraoral scans or the CT scans. We have requirement that we need one jaw full CBCT scan, which should have at least 250 micrometers or quarter of the millimeter image resolution, so it could be properly used for the image assessment. So when computer is encountering this CBCT volume for prosthetic instance, if we do not know anything, this is completely black space for our computer. We need to give some points or some surfaces which could be then recognized by computer and matched, and so we could have reliable reference for our prosthetic planning or the production of the guides. So we should be able to understand, to find, or to make some anatomical or artificial structures, markers, which will allow us to overlap these data, and we should know in which clinical situation which protocol will give an accurate overlapping of the data in which we could manipulate further on. So when we are talking about the markers, the upper part of the image is showing us radiological markers. One part of the radiological markers are gutta-percha points. They have defined number, size, of those elements and the position in which they should be, so computer could recognize those elements together on in specific situation. These kind of markers is used when we have completely edentulous patients, when we would like to match the data. This kind of the markers, where we have the situation where we have strictly predefined the shape, the size of the marker, we use in situation where we have available teeth, but with some problems which will make it difficult for us to match data. And also another part of the markers could be those anatomical markers, which could be recognized on optical scanners of the stone model, or it could be recognized on the intraoral scans, or could be recognized of the CT scans of the stone model. So let's go to the through the different situations, so I could explain this as much as is it possible. So first, we need prosthetic, removable prosthetic solution as a full denture, which will have appropriate size and the number and locations of the gutta percha markers. When I am telling that it is appropriate solution, it should be suitable for a patient both aesthetically and both phonetically, because both functionally, because those are the three most important elements which will be assessed when we finish everything at the end. The next thing, we need to make CBCT acquisition with this prosthetic element inside of the mouth. Then we will be available. Then we will be able to know about position of these gutta percha markers, and they will be utilized in the next step when we make a CT scan of the prosthetic elements alone. And then we have surface characteristics, and we also have this position of the gutta percha markers. So when we make and follow a procedure defined in the software, we will be able to overlap that data according to these gutta percha positions, which will overlap data correctly, and at the end we will have the position of the prosthetic element, which will guide us both to appropriate implant position, and also this inner part, which is now recognizable by the software, which will help the producer to print guided element, which will be used to direct implant placement during our operation. In the second situation, we will have a lot of artifacts due to a large number of metallic reconstruction in the mouth, and probably we will not be able in those situations to recognize appropriate anatomical markers, which will perfectly defined situation inside matching of the data. And that's why we will need this marker, which will be fitted to a suck down foil, which is made also with a radio opaque teeth in the position, and those data will help us so computer will recognize the position of the prosthetic elements, and the computer will recognize the inner surface of this stent, which will be helpful for the recognition and for the production of the guide at the end of our implant planning procedure. And also the most easiest way in which we can correlate the prosthetic part of the planning with the imaging findings is if we combine patient CT, where there are a lot of natural teeth inside of the mouth, so we know that we will not have a lot of artifacts, and we will be able to recognize a large number of the precise anatomical structures, which will help us and guide us to overlap data in a good quality manner. And these data could be from the stone model CT, it could be stone model optical scan, or it could be the intraoral scan of our patient. So what do? We recognize certain anatomical landmarks in our CT. We have procedure to follow in the software where we are adding these dots on anatomical parts which we recognized as similar. Then computer will count whether we have acceptable mistake. We will be able to control if we did our positioning well. Here, if the soft tissue position is on good place, or the tooth are in good place, and then we will have overlapping of the data, which will enable us to do the prosthetic planning, and it will enable us to produce the guided elements for the implant surgery. Before we go to the end of the presentations, we will go once more back to the on-demand software. We will try to activate case. I will have to turn this part with the English version off. I will need to activate the Serbian version because there is available part of the software there. We will just wait a few seconds. I hope that you do not find anything bad on my desktop. So we will look for the case. You can use this time while we are waiting for the appropriate patient to ask some questions. Also, you will have opportunity to ask those questions at the end of our communication. But if you would like to make any questions in this moment, it is also okay. Now we are starting our case. Although we have done this planning procedure before, I will just open initial data in this moment. So I will confirm the initial data. So we need to go for the tool here, which is called model. And in English, it would be align. So we should overlap or align the data. And it is the last protocol I showed. So the CT and the intraoral scan. I will choose here. I will choose here I will choose, it is not completely visible, but in the bottom I choose the data for this planning. I check if those are appropriate data for my orientation. Okay, that is appropriate scan. Then we will need to go for the next. Okay, now we will have to choose appropriate landmarks here. So as I know, this distal part is the one of the probably most. So we design the dots on both pictures. So one more here. Also, the program need at least three reference points, but in order to make the situation more accurate, you can add more points. So these numbers here shows us the level of the mistake, and this is a quite small level of mistake. So we can, for this instance, we can go next, and the computer will do the overlapping of the whole data. We can now check the overlapping data here, and on the bottom screen we could see that it is quite correct situation. Here it is difficult to look for the data acquisition because we have a lot of metal artifacts, but when we have a clear situation as this one here, or here we should, on anatomical points where a natural dentition is present, we should have no like white presentation of the tooth structure. So probably this is the good, but probably it could be a little bit better if we take some more time. But for the instance of this webinar, it's not that much important. We could do the checkup here if the data are correctly, if the data are correctly managed. There we could check for the soft tissue here and there for the tooth, and it is acceptable. Then we need to confirm our action, and now we will have the overlapping of the data with our prosthetic situation. So to go for the implant planning, we will choose our position. We will choose also the direction of the plane. We are tomographic plane. It is the tool or the ruler in the lower part in which we can incline this this tomographic section, which could be controlled and visible as a blue line in a panoramic picture. Then we could sharpen a little bit this structure, and then we could go for the implant placement. We can activate right click, then implant, then pick and place. Because the patients have another kind of the implants we previously used, I will choose that his type of the implant from the from this library. I will choose the dimension. I already know it, but it we could choose longer ones, so we could see what we need to correct and how we sometimes need to correct. Then we click on the position, mark position of the implant, and the position is placed there. So what I would like to have in the aesthetic zone, I would like to have one screw retained reconstruction. So that means that this part or the axis of the implant should not go over the incisal edge of the implants. It should be few millimeters palatal, so it could be done screw retained. Also, we need to check about distances from for the distances to adjacent structures. And as we said, we need to have at least 1.5 millimeter in aesthetic zone. We have 2 millimeters or a little bit less here, so that's acceptable. And we need to have at least 3 millimeters away from the neighboring implant. So probably in this situation, we know due to this distance that we will have a problem in configuring this papilla here at the end. We also can check that situation here, and in this also in this point we have visible that problem. So this implant planning correlation is showing us much more than the bone planning itself. Then we could check about if this is cervical area. I will do some random measurement just to describe cervical area. Here the dimension is not important, but we will measure the distance, and we know that it should be at least 3 millimeters from for the bone level implants from the neck of the from the cervical area. So probably because due to the length of the implant, I need to push it a little bit over. I could endanger myself to go and to go inside of the nose cavity. That's why I will go to the left, right click. I will go to the change implant. I will choose one step shorter implant, which will allow me to be much more flexible when I need to complete this procedure, and I will be away from the critical anatomical structures. And the last thing I would like to see here is that I would need to have 2 millimeters of available bone here, so that it means that we will need to do some bone augmentation here in order to have longevity of the planed case or longevity of the complete procedure. Also, we could go here to this situation, and we could compare this situation with the smile picture of our patient, and to decide whether the zenith of this tooth should be changed or should not be changed, and whether we should look and compare that situation according to the neighboring structures or implant teeth which are in the position in the moment. So probably this would be the one complete analysis. Just we would need a photograph of this patient with the smile, which will allow us and help us to combine this procedure to the end. We will go back to the procedure. So in the next two slides, I will show you some resources which will help you to understand and which will help you to fulfill some data missing after presentations. The main paper is the first one, which will lead you to the general CBCT issues. And the another things, although they are a little bit old and they are old 8-7 years, they are really important because they stress important issues about our work. So I will also stress the author, this Ali Tahmaseb. It is when you would like to know a little bit more about guided surgery and you hear for this name will give you really good informations how to be guided, and you should not miss this lecture wherever you find it. Also, one of the latest articles I have read it, and it is really good overview of the current recommendations for the clinical use of the cone beam in the implant dentistry is this one from the author with surname Jacobs. And you could look also for it to supplement this presentation data with the latest recommendations for in our field. Also, thank you very much for your attention. Now, if you have some questions or suggestions, you can send them to my email, or you can ask them now, and I will try to answer it live. Also, if you have any questions to Milos, who is responsible KaVo Care representative regionally, you can also give him some questions, and he will be more than glad to answer you. So I am waiting for any impressions. Also, I would appreciate a lot of if you could share some of your impressions during these presentations, and questions are welcome also. So waiting for the impressions and for the questions in the coming minutes. Matthias, do you have any kind of a comment, question, or anything?
So far, I can't see any questions, so we will wait for a few minutes.
We maybe now, because we do not have this need for I can stay for a few minutes live like this, and I hope that there will be some questions, because especially the end and this part with overlapping the radiological and prosthetic data can be a little bit confusing, but when you have opportunity to exercise in live on our workshops these kind of data, then just in a matter of the minutes, everything is clear, and then you are able to know how to do it, what to check, and how to proceed for another issues which are important for the implant guided surgery. Also, it would be important to say that when we are talking about navigational surgery, we have completely another procedure to match data, which is called tracing. But we will leave that for some another meeting or some another workshop or webinar or something like that. If there are no questions, then probably Matthias or Milos can conclude this webinar, and that would be everything from my side. And thank you once more for your attention.
That everything is clear. So thank you for the webinar for today, and see you next time once again.
Okay, thank you, Matthias. See you.
Sorry, there is only one question. Where we can find the presentation you talked about at beginning with the images.
Presentation. The beginning with the images. Which was at the beginning? Matthias, could you help?
If the question is about the presentation of the doctor, I think that the easiest way is just to look once again at the recorded version of this webinar, because each of the participants will get the link after the webinar will be finished, and each of us can see it how many times you would like to see it. You can always just click on the link and you will see the recorded version of it. So if you are asking
So
about
all data will be available. What was in presentation will be available for replay and for you to repeat later.
Okay, so I think that there are no more questions. So thank you once again and goodbye.
Okay, goodbye to everybody.